everything will work. So as we kind of wait for everyone to get in, I'll introduce myself and then we'll go around and kind of like introduce everyone one at a time. And if you have some initial comments, you can state them and then we'll go ahead and get started. So my name is Aiden. I recently graduated from WashU in the class of 2020. I studied pre-med. And I'm kind of the main organizer for these panel series, and I'm also going to be moderating it. The reason I really wanted to do this panel today is because the protests against police brutality have really dominated the news and social media, but there are a lot of other ways that racial discrimination and inequality impact our country. And minorities are underrepresented in higher education, medical and STEM careers. Underrepresented people also suffer from differences in access to quality healthcare and healthcare outcomes. And this is a problem that really the COVID-19 pandemic has highlighted specifically. And I'm really just hoping that this panel can teach us all something about these issues and mobilize us to address them alongside police brutality and other forms of racial injustice. And I hope, well, not hope, I'm very glad you all are here to join me in learning something about that. So moving on, I think we can start with you, Dr. Frazier, if you want to introduce yourself, make some initial comments, and then we'll just kind of move around the board.
Thank you, Aiden. It's a pleasure to be here. My name is Victoria Fraser. I'm the chairman of medicine at Washington University School of Medicine. I'm an infectious disease faculty member by training. I study hospital-acquired infections, antibiotic resistance, and patient safety. And we have been actively involved in COVID here, so the vast majority of the COVID patients are being cared for on the medicine service by the hospitalists, by pulmonary critical care docs. And our department is really working very hard right now on learning more about how to be an anti-racist, how to stand up and speak out against racism, how to recognize, you know, the subtle and sometimes not so subtle racism that impacts all of us and that that hurts and continues to propagate violence and disparities against people of color.
Thank you. We're going to go ahead and have Amy, do you want to introduce yourself next, and then we'll move on to Dr. England?
Hi, I'm Amy Sislow. My pronouns are she, they, them. I'm a senior lecturer in the Department of Women, Gender, and Sexuality Studies. And in that department, I teach a number of classes related to the topic of embodiment, but also girl studies. Anyway, it's confusing. I was actually trained in German studies, and my specialty is the 16th century history of medicine and science. So I'm kind of go in a lot of directions, but one of the main areas I focus on is transgender health and transgender studies. And that's been a focus of mine for the last 15 years. So I hope I can answer some of your questions, and thank you for including me.
Thank you so much for joining us. Dr. England, if you want to go ahead now.
Yeah, hi. Thank you very much for having this panel. I think it's incredibly timely. My name is Sarah England. I'm a professor in the Department of Obstetrics and Gynecology. I'm a researcher and a vice chair of research in that department. My work is really primarily focused on understanding preterm birth and the basic mechanisms by which this occurs. And for a long time, I have also been focused on STEM careers and have done a lot of mentoring of women in color who are interested in pursuing a doctorate in the biomedical sciences. So again, thank you very much for having me on the panel.
Thank you so much for joining us. We'll go ahead and have Dr. McKay introduce yourself, and then we'll end with Carolyn, last but not least.
Good afternoon, everyone. I'm Mary McKay. My pronouns are she, her, hers. I have the privilege of being the dean of the Brown School at Washington University. The Brown School houses graduate programs in social work, public health, and social policy. My own training really focuses on young people and their families. And my most recent work has to do with macro level, policy level, community level interventions that eliminate the structures that perpetuate racism, that drive poverty, and drive some of the educational and healthcare disparities that we talk about. And so I'm grateful. Aiden, I hadn't met you before, but you've assembled quite a panel of people that I expect to learn from. And so thank you all for being here and doing what you do. Thank you.
Yeah, thank you for joining us. We can't wait to learn from you and everyone else on our panel as well. And lastly, we'll have Carolyn introduce herself, and then we'll go ahead and get started.
I'm Carolyn Herman. I'm an associate dean in the College of Arts and Sciences. The hat that I wear that's kind of relevant to this probably is that I direct pre-health advising for the undergraduate program. And I've been at WashU over 20 years. And so one of the privileges of that is that I have gotten to sort of watch and participate in and sometimes lead a transition from a pretty big disparity in application outcomes for students of color and white students to a place for the last decade where our students have been equally successful in the application process. And so I'm definitely not an expert on higher education. I'm not an expert on, on much of anything probably, but I have thought a lot, read a lot, and worked really hard with my team, to bring our institution at least into a place of equity for medical school admissions.
Well, we thank you for joining us. We're going to go ahead and get started here. I just want to remind everyone in the audience that if you have things that you want to talk about or you want the panel to answer, please type them in the Q&A section, and we'll try to get to as many questions as possible. And also, at about 2 o'clock, we're going to open it up to live questions so people can ask in person with their voice questions towards our panel. So I'm going to go ahead and get started. I think the first question I want to ask our panel is, why do you think minorities are underrepresented in STEM fields and in higher education in general and these career paths?
Aiden, do you have a preference for who you want to go first? Maybe you should call on people.
Yeah, I mean, if
I'll
someone
be
feels comfortable
polite
leading off,
and
but if you want to
not
lead off,
start.
Dr. Fraser, you can, and then I'll try to bounce it around as much as possible.
Well, I think you bring up a really important point. There is an incredible shortage of Blacks and people of color in STEM fields. I'll probably speak from the medicine point of view. Medical school was traditionally and historically from the beginning white men, and most medical schools refused women and refused people of color, which resulted in some historically Black colleges forming and medical schools, in fact, so that people of color would have an avenue for obtaining higher education and medical school education. But I think there's been, structural racism in our institutions and in many of our policies and practices that have made it even more difficult for people to get into medical school and to do well in medical school and to get residencies and fellowships and positions. And so some of it has been just, the constant oppression and microaggressions that people of color face, being constantly challenged that they weren't smart enough, weren't good enough, being taken for non-medical students, being stopped by security and questioned for who they are, and that creates incredible stress. We also have had grading systems that were not always objective and that were subjective, and led to people who are the majority, white people, getting higher grades, higher honors and awards. So things like having people who've gotten honors and awards be the only people who can nominate people to get honors and awards, and then having people vote. And so if you're in a minority and you're kept out of the inner network, then you're less likely to be nominated for honors and awards. If it requires a vote of the majority, if you're in the minority, you're less likely to be elected for these honors and awards. So things like AOA, which is a honorific society, Alpha Omega Alpha in medical school, now actually has been stopped at Washington University School of Medicine and many medical schools across the country because of the structural way that it was facilitating ongoing racism by disproportionately giving this honor to whites versus people of color. and the grading system, which was heavily subjective, in which people would pick honors or high pass or pass, were heavily subjective. And so that recently has been studied and changed so that there are grading teams. So instead of an attending and a resident making a subjective decision about a medical student getting honors or pass, they describe the competencies, the behaviors, the characteristics, the knowledge base to a grading team that then consistently applies grades based on the competencies that people have achieved. And the goal of that is to have more consistent, more equitable, more objective grading that won't be influenced by people's skin color or their tone of voice or their behaviors that might result in them being undergraded and then not being eligible for honors awards for top residencies. And so I think we are looking very hard at the things that have been, I think, really just ongoing evidence of white privilege that then facilitated the success of whites, but doing so in a way that disadvantaged Blacks and people of color.
And if I could add a little bit to.
Yeah, absolutely. Go ahead.
Yeah. So when I think about, you know, the people that wind up in medical school or in STEM fields, I have to go back well earlier, decades earlier, to what I call the pipeline, and the very leaky pipeline where who gets through has often been centered in whiteness, in maleness. I will just share that when you go to Dr. Fraser's office, you see a stunning wall as you wait for her to be free. And those are prior chairs of her department. And so as I waited for Dr. Fraser to be free, I counted exclusively white men and then Vicky's picture. And that is in 2020. So this pipeline to these fields, medicine to STEM to, and how one gets through and how one gets diverted starts very early and is systematically, you know, produces the outcomes that we have today. And so as I think about all the wonderful things that Dr. Fraser is talking about in terms of what's happening in medical schools now, what's happening in admissions, Dr. Herman mentioned that, you know, we have to go earlier and earlier to understand how the outcomes that we're getting are produced and where we fall down. And those are based in systemic kind of diversions of people of color out of particular fields, and they're incentivized by what we call merit systems. And so I'm really glad to be on the panel to talk about some of this.
Can I also add to that, right?
Yeah.
Is that I have been a professor for a long time, 23 years, and what has been interesting to me is that every place that I have been has focused on recruitment efforts and getting people into the pipeline without always worried about the culture that we were creating at the schools for people to actually stay in the STEM fields. So when I was an assistant professor in '97, of those, only 2 of us have made it through, and I'm the only one who's a full professor today out of 10 people. And a lot of it was that when a minority faculty comes into on the campus, a lot of times people, I call them, will like diversity track them, where they want them to be on every diversity panel, give them a lot of extra service work. And it is something that is, you know, psychic pay. It feels great, but it never ends up in your promotion and tenure dossier. And so I also feel that it happens very early in the tracking, just like, you know, Vicki and Mary talked about, but it also happens later on in that when I came to WashU 9 years ago, I got a call from the St. Louis American that they wanted to interview me because I was the first African woman who had reached the level of full professor. And I said, that cannot be, but it was true. And it is not because there are not a lot of talented people out there. It's just, I feel that there has to be more of an emphasis on the culture that we are creating for everybody to be successful, and not, and in order to enhance their career in whatever they choose they want to be successful in. So.
If I can jump in.
Absolutely, go ahead.
So to what Sarah was talking, actually just this kind of responds to what a lot of you were already saying, but this isn't really my professional experience, but I'm thinking all the way back to recruitment to college. So as you can see, I'm white, but I'm a graduate of Flint Public Schools. I was one of the few white people in my grade, and the Ivy Leagues recruited heavily in my public school, but they condescended to us. They made it sound like they were doing us a favor by taking people from our school. And while there was a lot of encouragement, so let me go back a bit. This would have been in the late 1980s, early 1990s. But there was a certain way that they talked to us as a group that was different when they spoke to me, white person alone. And so I got this interesting viewpoint even back then about how they want them to join, but at the same time give off vibes that you're unwelcome. So I just wanted to share that experience that I think we still need to work on today, that universities recruit heavily, maybe not in the best way, and then need to think about what to do when they bring people of color who are underrepresented to their campus.
Thank you all for sharing. Would you like to add anything to that, Carolyn?
I certainly want to agree with Mary that the problems began very early. One thing I do is I teach a little bit and advise at our prison education project at Missouri Eastern Correctional Center. And so one of my students, one of my advisees there, actually just did a capstone project on systemic racism in St. Louis schools, and wove in his own personal experience. He's from St. Louis. His name is Tori Adams. He did a fantastic piece of scholarship, but he quoted a report from the St. Louis Post-Dispatch that in his capstone, elementary schools in Missouri suspended 14.3% of Black students at least once in the 2011-2012 school year, compared with 1.8% of white students. So there's, so many more times difference. And he discusses at length how when children are out of school, how much that disadvantages them educationally, but also how much it disadvantages them socially and sets them up for basically being labeled, sort of what expectations we know from research that what expectations instructors have for students is powerful in just how everything about their education plays out, from their, how they are perceived as a student to then what scores they're actually going to get on tests. So the problems start very, very early, that in even very young children being suspended. I mean, if the kinds of schools that probably most Washington University students attended, if you have a very young child who's not behaving correctly, you teach them how to behave better. You shape their behavior. You don't assume that they need to be suspended or put out. So there's an incredible disparity that begins very, very early, but it also never stops. Obviously, all of the students who got to Washington University as undergraduates are highly capable, and maybe were protected from some of this earlier on, more likely survived it in sort of in spite of, the disadvantages and disparities they faced, but they're still treated differently. We still see disparities in grading that are not explained by differences in test scores or any other, objective criteria we can find. We know that there are differences in grading that are unexplained other than by, the race code that's sitting in our admissions database. So the problems don't stop at the university. And in my team of pre-health advisors, we've tried to aggressively advise around the disparities in the classroom.
Right. Thank you so much, everyone, for sharing. My next question is kind of related to something you all were talking about, and it's how systemic problems, in this education pipeline start early and then propagate as you move up through higher education. And I'm kind of wondering what kind of things have been done to address these issues at all levels. So, there can be underrepresentation due to lack of quality access to education in underserved communities, and there can be merit-based programs that promote these, systemic discriminatory policies that may promote certain types of people over others, right? So at all levels, and to your understanding, what is WashU and maybe programs in the greater St. Louis community doing to address these issues?
So I feel like I need to say something because my department was founded on this idea, right? I work in the Department of Women, Gender, and Sexuality Studies, which was founded because we didn't have a chance to learn about women in history. We just didn't. It wasn't part of the history program. We didn't get to read literature by women. So the entire department, which couldn't have just been founded on its own. It had to be approved. There was a process, and the university had to say, yes, this is valuable. So one thing that my department as a whole does is to call into question patriarchal structures. And if we can be educated to unpack the structures that are causing some of the systematic oppression, we can change it. And on that note, though it's not my department, the Department of African and African American Studies was founded a year before my department with the same understanding that we need to do critical race theory. We need to educate people on how to critically investigate the structures that lead to oppression. So those are the academic things that Washington University has done. And I should be clear that my department and the Department of African and African American Studies were founded in the 1970s. And I know the Women's Studies Department at WashU was one of the first in the country.
Yeah, thank you so much for sharing. I kind of want to bounce this question to Carolyn because someone in the chat actually asked a question. Sorry, I accidentally muted myself. And they were talking about how you mentioned that the selection process has more equity now for students applying to advanced degrees in science and STEM fields in med school, right? And I guess I just wanted to ask, what types of programs and policies have been implemented to help make this happen, to make this a reality?
I would say one thing we've done that has been, I think, has worked is as pre-health advisors, we really decided as a team that every student at Washington University is smart enough to be a doctor. We don't do any gatekeeping. We don't tell people that they're probably not cut out for this. We try to be in a stance where no matter what has happened for you academically or personally or whatever, we just ask, what's the distance between where you are now and what you would have to demonstrate in order to be a successful applicant? So how can we strategize with you to get to where you want to go rather than telling you that you're not doing it right or you're not on the right road? I think that benefits all students. And like many things, if we do them correctly, it really is all boats on a rising tide. So I think that benefits my white students too. But we probably reach out earlier and we more aggressively try to message that to students of color because they're not necessarily getting that message from any place else but the pre-health advising team in some cases.
So I could give you an example of something that was an aha moment for me. We traditionally had more residents that were Caucasian and more residents that were men compared to women. So in the summer of Michael Brown's murder, that is the recruiting season. So that we were bringing medical student applicants in to apply for medicine residency here. And we thought, this is the worst possible time. Who will want to come here? And how can we really recruit the best and the brightest? And also, how can we be more diverse and inclusive, particularly during this super stressful time? And so, we looked at some of the structures that we had in place for decades for how we chose who got selected to be interviewed here in the Department of Medicine. And we recruit about 50 interns every year, and we get 4,000 applications. And we traditionally interview about 400 people to then do the rank list to get down to our 50. And when I started asking a series of questions about, how we did this, it turns out we had some very subjective, very arbitrary cut points that effectively excluded a large proportion of people of color from even being interviewed here. So first we started with peer institutions, and we, selectively tried to recruit people from peer institutions. And the peer institutions were a very small, very elite group of schools. So that cut out a huge amount of diversity. And then we had a test score that was pretty arbitrary. It was quite high, but pretty arbitrary. And just by changing the test score by about 5 points, which was not statistically different and still was super high, we had access to many more people of color and people from diverse backgrounds. And when we changed the list of peer institutions to the top 25 schools as opposed to the top 10 schools, it also increased the number of students that were eligible. So, we had some really structured racist things that were selectively cutting out Blacks and people of color from even being eligible for interviews. So, so we changed those. And also, when we invited people for interviews, we used to do that in a pretty, sort of random way. We just let people pick dates that they wanted to come, and we interview people usually on Fridays, and we have a very special program. But by doing that, we had some days where there would only be one Black person interviewing or one Hispanic interviewing. And that doesn't feel good or look good to people who are interviewing. So we structured the way we do interviews differently so that we scheduled people to come so that they never would be the only one. And so we tried to schedule people so that there would be on the days that we had more diversity, that it really looked and felt more appropriate. Now that meant that just because of the disproportionate numbers, there were some days that we interviewed and it was all white people, but we never had somebody who was, one Black person out of 100 people interviewing that day. And then we did second visits. We set up second visits for people of color to come back. We made sure that we had kind of a special meeting the night before for all the people of color who came in so that they got to meet more Black faculty, more Hispanic faculty. They got to meet more residents and talk about how life was here as a person of color. And I think we really changed the way we did the recruiting visit, and we did a lot more training of, what was appropriate and what was inappropriate to talk about and to ask people about. And that made a dramatic difference in our ability to recruit and retain a more diverse house staff. And that I never would have, recognized that we were doing that, but our policies were racist and were effectively excluding people. And by dismantling that, now we interview a lot more people of color. We interview a lot more women. And our residency program has become closer to closer, 50-50 men and women, and also about 20% people of color, which was a dramatic increase.
I'm really happy to hear these initiatives are being taken. And before we kind of move on, because I do want to get to healthcare disparities and make sure we have time to talk about that, I actually want to bounce this question to Dr. McKay, because I understand you have a lot of background in social work. And I'm just kind of curious how, social work programs or community service programs can maybe help address unequal access to education and kind of some of these racial biases in our education pipeline.
So if I think about kind of how you dismantle kind of structures perpetuated by racism, I think about two kind of types of interventions. I think about how you have interventions that go directly at the root causes, and then interventions that go at the consequences of structural racism. So if I think about my profession, social services, youth development programs, counseling, those are the really important interventions at the consequence side, right? That populations that experience disproportionate stress, barriers, are burdened with different kind of health conditions, social conditions, exposure to trauma. Social services, counseling services, that kind of whole part of my field is really necessary to help people recover from the consequences of racism. What can get very, though, confusing in a profession like mine, although I would imagine this gets hard in medicine as well, is how you actually operate equally, if not really disproportionately on the root cause side, which is what is causing kids and families to be in this pipeline of needing social services in the first place, right? What is causing, students to need the extra support so that they can graduate high school and go on to college and stay in this pipeline? And that's actually where you really have to take a very discerning look at our public policy, the supports that we provide to keep people in the pipeline or ensure that it's very leaky. And it's that root cause work that sometimes feels political, but is critical. If that you don't do that work on the side of my profession, you keep having kids and families in a pipeline and in some ways then addressing those consequences. So when I think about our profession, it's at least 50% root causes as well as consequences. There's a question in the chat, and so that I can start to address that around.
Yeah, feel free to.
What can make graduate programs more diverse? I'm really proud of the Brown School that for its tenure and tenure track faculty, we have the most diverse faculty on the Danforth campus. In terms of a graduate education program in the Danforth campus, we have the most diverse student body from around the globe, around the nation, from our local community. But what that also creates within the Brown School is the pressure to be sure that we really support that diverse student body. And educational institutions are not often equipped or ready to support that diverse student body. So there's a critical mass, thank goodness, of faculty at the Brown School, faculty of color and their allies that are really working hard to dismantle the things that Vicki's right. Within our institutions, you have to not only look outside the institution, but inside. What do you control? And so one of the things that I do support our diverse graduate students at the Brown School is we are really the only school of social work or public health graduate school that we know of that does both merit and need-based scholarships. Usually graduate programs are just merit-based scholarship, and we're switching next year to proportionally more need-based as opposed to merit-based. And so that's something that you can control, but historically was baked into graduate programs. And and I'm happy to talk about other ways that you support, both engaging diverse students, but then our job, one of the things I track very closely as a dean is the proportion of students that graduate. And I'm happy to report that about 98% of students graduate from the Brown School. It's not easy. There's a lot of things that we need to address, but you have to really pay attention to those outcomes and then collect data, not just perceptions about how things are going. And so I'm happy to talk about that too, if that's of help.
Yeah, thank you so much for sharing it. I think we'll definitely have some questions in the live Q&A about those topics for sure. I kind of want to switch tracks a little bit And I want to start with Dr. Fraser about these questions because I do want to talk about healthcare disparities and especially their effects being kind of exacerbated during COVID-19. So just to kind of get us started, I want to ask, what really are healthcare disparities, what causes them, and what is being done to address them? And then we can kind of open up discussion to the rest of the panel, but Dr. Fraser, if you'll lead us off, that'd be fantastic.
Thanks so much for that question. You know, we have huge healthcare disparities in this country that are disparities related to race, ethnicity, religion, gender, socioeconomic status, and they're very fundamental in the United States because of a number of factors. We have health disparities that come out of food deserts that are in neighborhoods where people don't have access to healthy foods. We have health disparities that relate to people living in neighborhoods that are closer to toxic waste dumps, that have more air pollution, more exposure, and often those are underrepresented minorities that are in those communities. We have disparities because of lack of access to healthcare. We have fundamentally a for-profit healthcare system, right? We don't have Medicaid for all. We don't have the same level of healthcare delivery for everyone. People who have jobs, you know, have health insurance if they work for a company that's big enough to have health insurance. But we have a very unfair system, right, in which people can't access health care if they don't have insurance or they don't have money to pay. So that means that people are not necessarily getting their preventive care, they're not getting routine care, they're not getting the medicines they need to stay healthy. And so common diseases, diabetes, hypertension, COPD, asthma, disproportionately impact people who have limited access to healthcare. And then those diseases get worse because they don't have access to free medication or affordable medications. So even some basic things like having your medicines delivered to you every 3 months, as opposed to having to get a refill and having to go to the pharmacy, creates a disparity where people may not be able to get their medicine and then can have bad complications. So there are a number of diseases that disproportionately impact Hispanics and Blacks and women. And so worse outcomes include more hospitalizations and greater risk of death in many conditions. There's a fair amount of data that people of color are less likely to get pain medicines. They're less likely to get a cardiovascular workup for their chest pain, and their diagnosis is often delayed or missed, all of which contribute to worse health outcomes. So those are really structural things that need, you know, lots of levels of intervention if we're going to try to improve health outcomes and make it truly equitable for everyone.
Does anybody have anything they'd like to add to that?
I also want to say in women, Black women have about a 2-fold higher rate of preterm birth. And in our area, that is, you know, if you are in North St. Louis, it's about 17%, but if you're in Clayton, it's about 8 to 9%. So that you're talking only about an 8 miles difference with a 2-fold higher disparity. And that is a perfect time to intervene because we do know that in utero exposures can set you on a bad trajectory for a very long time. So if we could even do something as simple as getting a lot of pregnant women to stem this off into a better trajectory for their children, then it would be a lot easier because that just self-perpetuates, along with the many things that Vicki is also seeing in internal medicine. So we have a lot of work to do in regard to health disparities. So hopefully, I think people are aware of it and are studying it, but we have a lot of work to do.
Sarah, could you talk for a minute? I get to work with your amazing collaborators at the hospital. I work with Ebony Carter and some of the unbelievable work that you're doing to try to get Black women's voices into prenatal care, into interactions with healthcare providers. You're doing some amazing work with an evidence-based group prenatal model called Centering. You're really trying to change the way care is delivered, and to not just study disparities but eliminate them. And I wonder if you wanted to say a word about that.
Yeah, so some of the young investigators, Ebony Carter's work is great, is that a lot of times we focus on just a lot of the mechanisms by which this occurs. For example, preterm birth or gestational diabetes. And what she is doing is that she's had a lot of success just bringing in women together in a community-based group to talk, and it's called Centering Pregnancy. And when women come together as a group and have a social structure and check in with each other, they seem to have better results. And that has eliminated a lot of the disparities. And it's also listening to women during their pregnancy and not always telling them it's a two-way conversation, right? It is not a one-way conversation. And so I think that we have to rethink how we are approaching medicine in some cases, but this is one way that has been very successful, that seems really simple, but it's been an amazing setting these women in a much healthier trajectory for their pregnancies and how their pregnancies progress. So thanks.
I think there's a really wonderful example going on with Siteman Cancer Center in North County with breast cancer also. So cancer disparities are quite significant among African Americans. Blacks have higher rates of breast cancer, really severe breast cancer, kind of delayed diagnosis of breast cancer, also colon cancer. And so if you're diagnosed late, then you're less likely to benefit from treatment, less likely to have all the treatments available to you, and at greater risk of recurrence and death. So Siteman Cancer Center has really done extraordinary outreach with a number of the faculty in the Prevention and Control Center led by Dr. Graham Kolditz, that really brought care to patients with a lot of education, mobile vans, mobile mammography, and have already reduced the disparities within a relatively short period of time by getting people access to mammography so that they could pick up earlier stage breast cancer so they could have more effective therapy.
And what I think is important about both of those examples, just because I have the honor of having some faculty colleagues that work with your colleagues on both of those initiatives, is it's both, the goal is to eliminate disparities, but the leaders of those studies are Black physicians, right? Just like, you know, at the Brown School, we have a number of endowed chairs held by Black faculty, that it matters not only the interventions, but also who is leading those projects, how the questions get asked differently, and that relates to the pipeline that we talked about earlier. And so I think that work sometimes, you know, doesn't always get talked about, but Dr. Fraser's right that the most recent data suggests that you can eliminate that cancer disparity, but you need to reorganize care, and we need to have, you know, different leaders, and then faculty like myself really champion and supporting the way that Dr. England, Dr. Fraser does those faculty colleagues, so that they are in leadership roles. Because Dr. England, it made me sad that you were the only, if I understood you right, a Black professor in that space. And so that's, I think that's really the issue, is it's both who's there, what they're working on, how we support that work, that we can really change these systems.
I'd like to say we're to 4 now also.
That's fantastic news.
If I can just jump into
Yeah, go ahead, of course.
that one thing I think that it's really important to not lose track of is that while it's amazing that we can reduce disparities on something as critical as cancer, that is amazing. When we also improve the structure of healthcare delivery so that the most vulnerable and the most at-risk population benefits, it makes it better for all of us. I get my mammogram every year now because the van is there in the North Campus parking lot and it's super convenient for me. And I'm busy and I wouldn't always get to it. And I just wouldn't, I know, because before we had the mammogram van, I didn't. So, you know, I think it really structuring things so that they work for everyone benefits us all. And I really, you know, maybe it's easier for everyone to join in and being allies if they, you know, kind of reflect on the fact that they stand to benefit as well in really material ways.
Thank you everyone for sharing. Is there anything you would like to add, Amy, to the discussion?
I mean, I just keep thinking in terms of access to healthcare, and this is particularly problematic for trans people in the St. Louis region. There are a lot of basic services that people are lacking. Access to hormones for people who want to medically transition. Let me be clear. People who are transgender do not all want to medically transition. But for some who do, it is a dire need to have access to hormones. And there are people buying hormones on the street right now. Sometimes people are searching and searching for an endocrinologist who will treat them and just having difficulty getting an appointment. We don't have a healthcare system in St. Louis that is supportive of adult transgender people. We've got a great system for people 24 and younger through the SPOT and through the clinic that was set up at Children's Hospital. But despite the fact that we have two huge university hospitals in St. Louis, getting help with medical transition or just basic health care when you're trans is a major impediment right now.
I really thank you for bringing that to light, because as much as we talk about, you know, people of color, women, you know, and the disparities they face, it's really important to think about the LGBTQ community as well and the challenges, the specific challenges that they face in these systems as well. And I kind of want to, sorry.
You know, trans
Go
people
ahead.
of color are dealing with multiple systems of oppression. And this also leads to people buying hormones on the street.
Hayden, can I say a word about the SPOT? Because your audience might not know what that is, but it's a pretty effort, really focused in on adolescents, young adults, and meeting their comprehensive human needs. So in addition to their healthcare needs, in addition to LGBTQ youth, then thank you, Amy, in the chat that sent you to the website. But one of the things I have people, leadership from the SPOT, come and teach in my classes every year. And the leadership had to make really tough decisions around how to organize care where they could eliminate every barrier that they could. But some of the barriers were embedded in our funding sources, the way we are funding healthcare, the way we have to get reimbursed for different types of kind of healthcare interventions, and had to look for alternative pathways to provide comprehensive human care that was needed. It was a true and continues to be kind of a sheer commitment on the part of kind of the institution and the leadership, but really hard because constantly also constrained by federal policy, by healthcare policy, by who we insure and who we do not. And so incredibly important that you can create something like the SPOT, but sustaining it in a policy environment that puts a lot of pressure on it not to exist or not to exist in the way it does, really, really complicated. And that's really what we're up against when we think about all of the types of either prevention programs, which we hardly fund, or intervention programs that are narrowed by what we consider appropriate or not for insurance funding. Really, there's a lot going on that all stacks up against, it stacks the getting the outcomes that we currently get. But check out the spot, they're amazing.
I really appreciate you elaborating on it, because this definitely seems like a program that we need to be aware of and we need to be supporting as well moving forward. To kind of move into the wrap up of our discussion, I wanted to talk a little bit about COVID-19 because it's a very relevant issue right now. It's been widely reported that COVID-19 disproportionately affects Black people. And I was just wondering, what is the role of healthcare disparities in this, and what can we do to specifically address these issues during a pandemic?
So, clearly, COVID has disproportionately impacted Blacks and people of color with reduced access initially to testing, and in many communities, including our own initially. I think it's been rectified now, but most of the testing sites were set up in ways that were disadvantageous to people of color. They were either too far away or not aligned with public transportation or easy access. Um, and then many people of color work in essential jobs, right? So they are caregivers. They work in hospitals, they work in nursing homes, they work in skilled nursing facilities and rehab. They drive buses and are teachers, and so had potentially a lot of exposure in meat processing plants, in which they weren't always provided the optimum personal protective equipment or social distancing to protect them. And so they got higher rates of infection. And once they had higher rates of infection, they have also had worse outcomes in many cases, with higher rates of hospitalization, higher rates of needing to go to an ICU, higher rates of being on a ventilator. And some of that relates to coexisting comorbidities, hypertension, cardiovascular disease, diabetes, and obesity. But some of it, again, is delayed access and late recognition. So I think the good news is we have learned a lot about COVID, and so our mortality rates overall are going down because we have more effective treatments. We have some treatments now with remdesivir and with steroids. We know better how to ventilate people and how to use prone ventilation to maximize their recovery. We have set up more testing, but part of our problem in the beginning was still very insensitive, culturally insensitive, kind of racist care, in the sense of thinking about how we communicated with people of different backgrounds about the importance of testing, the importance of social distancing, the importance of using a mask, and then even delays in making masks available to people. And really thinking about how much harder it is to do social distancing if you're in a multi-generational household, or if you're in a household where you have a higher family density, family number, people living in the household. So, I think for any of a number of reasons, COVID has disproportionately impacted people of color and also impacted people of lower socioeconomic status. And so we have to keep working incredibly hard to make sure that we are providing culturally sensitive care, good communication. So Dr. Lori Punch, one of our surgical trauma faculty here, did an extraordinary job really reaching out to the Black community in North City and North County with tailored videos and social media, so that she could talk to people directly about what COVID is, how it's transmitted, and what people could do to protect themselves. And so I think that was very successful, and she came up with very clear messaging that fostered a greater appreciation, particularly during a time when there was incredible mixed messages, coming out from lots of different areas. And I think, from a health and safety point of view, the medical community has not always done the right thing by the Black community, right? We have some horrible history where we did incredibly inappropriate experiments and research without informed consent that was unethical, illegal, and so people know about that. So it's not surprising that Black people don't always trust the white healthcare establishment. So I think we have to work even harder to show people that we do care, that we understand, and that we are providing equal access and the best possible treatment and care to all the communities.
Thank you for sharing. Is there anyone that would like to add to that? Okay, I'm gonna go ahead and ask one final wrap-up question, kind of to just like tie everything together a little bit, especially with regards to the educational and healthcare discrepancies that our country faces. Really, we've seen some improvements, right? And you kind of touched on this a little bit. We've seen progress. Things like the Affordable Care Act and Medicaid programs have helped address the impact of these disparities. But really, what is the ultimate long-term solution to these types of things? Is it free universal healthcare? Is it college education that's accessible to everyone? Public schools that are accessible to everyone, high-level education. Just give me some of your thoughts on what you think will ultimately address these issues in the long run, and when will it be possible to kind of see some of these things be implemented? Tough question, I know.
I'll try, but that is completely a really challenging question.
It also may not be one that has an answer. So really, I just kind of want to open dialogue about it.
So I guess what I'd start is by saying that right now the playing field is completely uneven, right? And so until you kind of invest, I can go back to Dr. England's population, until you invest, before a child is born, and then all the way through to the outcomes that you want, which is medical school and then beyond, tenured professors. You have to recognize that we are on faulted ground, that it's uneven, it's historically been abusive, and that at every juncture, you can see things that we need to dismantle. And so I think that what makes me more hopeful about today's dialogue than I have been previously is there appears to be an increasing acceptance and recognition that when you begin a country where there are enslaved people and not enslaved people, and that all the decisions that you went from there need really serious kind of dismantling, right? That every assumption that you make when you start on such faulted ground needs to be questioned and re-questioned, and that's our responsibility from each one of our positionality, but that's our also responsibility as a collective, right? I haven't heard that discourse as clear as I do in the current discourse, and so that holds promise, I think, in really thinking about the uneven ground that we need, and this is where Dr. Herman, it gets complicated. We need to repair that ground, and so that means that there needs to be disproportionate attention to those that really have been so burdened, and I think that's sometimes when you hear talk of reparation or disproportionate investments in people of color or Native populations, that type of repair, it never, I haven't heard as clear, at least willingness to engage in those type of conversations, but I think that is what it's going to need, it's going to need all of us to be working within our different positionalities and different systems, but that won't be enough. It's going to really need to be this kind of, they've been talking about it as a reckoning or a real humble acknowledgement and then repair strategy. And I do a lot of work globally, and that's often needed, when there's been a real rupture in a society. And I think that that's really where we are in terms of needing to repair that rupture. So hopefully that starts you off and how hard this is going to be, but how pervasive it'll be in order to change things.
I guess just to add to that, because I have lived outside the United States and it gives me some perspective, that we need as a country to think about healthcare as a right and not a privilege. Because I've lived in Germany, and everyone is presumed to have access to healthcare, including rehabilitation services, mental health, and that's just a given. Like living in that culture, and then coming back here, I can really see the difference in that some societies have decided as a country, we care about everyone. The health of each individual is important to us as a community. And the United States hasn't really thought that way, though the pandemic may be pushing it. Maybe the pandemic is making people finally realize that if your neighbor's sick, it's going to affect you. Like everyone who lives around you needs to have access to healthcare. But again, our system in the United States really understands healthcare as a privilege and not a right. And I think that's something that we really need to dismantle.
And you could apply that same statement to public education.
Yeah.
Access to high quality supportive public education. And that's why the topics, Aiden, that you picked were so important, because those are pillars of a society that we need to really in some ways reinvest and divest in aspects of it and reinvest in others. Yeah.
I agree completely. I would love to have, public health care for all and have the equivalent of Medicaid or Medicare for all. I think that would make a huge difference. And obviously, free public education would make equal, equitable, high quality public education would make a tremendous difference. We do all have the opportunity to vote for Medicaid expansion, so I want to make a plea here for everyone to vote and to get out and to vote for Medicaid expansion. In the states where Medicaid has been expanded, it has actually made a tremendous difference in access to healthcare and reducing health disparities, but also it's improved the economy, right? And it ends up saving money and being better overall. So we are obviously actively engaged in trying to help people get to the polls to vote or to do mail-in ballots. Because of COVID, people can do mail-in ballots. So I hope we get everybody registered and get people to vote.
So that vote is August 4th. And in collaboration between the medical school and the Brown School, there is a 3-part series around that you can learn a lot about Medicaid expansion and its potential, the models around economic impact for our region, around the health and well-being of children and their families. And so if you go to Clark Fox Policy Institute, you'll see all the details of that 3-part series. So if you want to be educated before your vote and have real science behind, there'll be medical school colleagues, Danforth's faculty, lots of voices from the community around Medicaid expansion is potentially a real benefit to our region.
Okay, thank you so much, everyone, for sharing your thoughts and being committed in trying to fight against these issues. And on top of that, just taking the time to educate me and everyone else who attended our panel. I think we're going to go ahead and open it up to live questions now. So how this will work is you'll see a little icon next to your name where you can raise your hand. If you raise your hand, I will unmute you and you can ask your question, and then we'll just kind of go throughout, try to get through as many questions as we can in the next like 20 minutes or so, and we'll wrap up from there. So if anyone has a question, feel free to raise your hand. But again, thank you to all of our panelists for such a wonderful discussion. It was very insightful. Okay, we're going to have a question from Stephanie here.
Hi there. I was just wondering, a lot of people are unable to advocate for themselves in healthcare because they aren't really health literate. So I was just wondering on what you guys think about how we can increase the health literacy rates in the country and even like teaching it as early as in primary education.
That's a terrific question. I think we obviously need more education at a very early stage about healthy behaviors, health promotion, both related to nutrition, exercise, avoidance of, toxic things, and helping people refrain from smoking, substance abuse. But I think it should happen at every level, right? Both not only in grade school, high school, college, but also in the community, and that's a major part of what public health officials do, as well as doctors, nurses, every day. And so I think making that information more accessible, more understandable is really key, because sometimes we don't speak in people's language, and we don't always speak in ways that people understand. So we have to work hard to make sure that people really understand, and often that they can retain information, and then they can act on the education. Because it's one thing to try to teach people what good nutrition is, but if they don't have access to food, and they don't have affordable food, then that's the barrier that has to be removed as well.
There's a couple of really important points embedded also in our Medicaid expansion discussion. What they call Obamacare had the opportunity that you could actually invest in health literacy and preventative programs in a way that you typically could not. And so to kind of think about kind of different structures that we invest in public health. I mean, if COVID has shown us anything, it has that many of our public health departments have been really kind of dismantled to bare bones, and need to be rebuilt. From a population perspective around how we help the population and partner with them to have the healthiest life they can, will save us millions of dollars in the healthcare end. And so health literacy, education, investment in overall health and well-being as early on as possible is really needed. That's a great question, Steph.
Okay, yeah, thank you for such a wonderful question. I think we're gonna move on to Annie. She has another question that we will ask.
Hi, I have a question pertaining to LGBTQ rights in healthcare. So with the recent removal of healthcare protections based on gender from Section 1557, the LGBTQ community can now essentially be discriminated against in the healthcare industry. So what has WashU done to combat this and support the LGBTQ community, and what can be done in the St. Louis County, and this might be a little broad, but even across the nation?
So thanks for asking that question. That the removal of the healthcare protections for the LGBTQ community is outrageous and terrible and bad, and we are morally, ethically, completely opposed to the federal government's policy on that. We have a very active group that started in the Department of Medicine, but actually engages throughout the whole medical school, called OutMed. So we have faculty leaders, we have faculty, staff, and trainees that participate. They did an extraordinary job developing a strategic plan, curriculum to help develop really LGBTQ friendly care. And we have a website and educational programs and allies and champions that sign up, in addition to the trans clinic for kids. We have a very active program on the adult side also to care for adults with LGBTQ and trans needs, and make sure that we do that in a culturally sensitive and appropriate way. That said, folks are very vulnerable in this community. They often don't feel safe seeking healthcare. They worry about discrimination, and there's very clear data that many healthcare providers don't take appropriate histories and don't really understand how best to take care of patients. And so as part of the initial work of OutMed, they really got in EPIC, which is our electronic medical record, the correct sexual orientation and gender identity criteria and questions built in so that those could be asked correctly, and that people could be cared for. We've set up training programs for our medical assistants and our healthcare workers so that they ask people's preferred pronouns so that they can really be spoken to in a culturally and sensitive way. But we have a lot of work to do in this area because many people have been discriminated against for a long time based on their sexual orientation or gender identity. And so I think this is an area of ongoing importance, and I would say Washington University School of Medicine is very committed to providing high quality care and supporting the LGBTQ community here in the region.
Does anyone have anything they'd like to add to that? I'm kind of curious a little bit, kind of going off this question, like as a community, you know, and standing up for LGBTQ people, how should we be reacting to our government kind of curling back some of these rights and these privileges in the Affordable Care Act? How can we address these issues as citizens?
Vote.
Yeah,
Contact your representatives. Contact them frequently. Tell them that you disagree. You can also support advocacy groups that lobby on behalf of LGBT rights. There are many of them, but directly contacting your representatives on the federal, state, and local level is super important.
that our collective level of engagement, both within the institution that gives us positionality and influence, but also as engaged citizens, the level of unalignment, is that a word, between the values of the professions that I represent in the graduate programs of social work, public health, and social policy, and some of the, both explicit public policies, the discourse. It has been a time where there is such a gap. And so vote, be engaged in your personal life, do everything you can from whatever platform you can to contribute to the connection and the fairness towards others. I mean, this is a time that we need heightened levels of engagement. And I think that's this fall, we need to demonstrate that we are engaged and really dissatisfied with the state of the recent rulings, the policy statements, our elected officials, and so that level of engagement, I think, directed towards our federal and our state and our local officials, really needs to be quite significant.
You know, I think sometimes people think I'm just one person, what can I do? And I can't make a difference. But in reality, one person can make a huge difference. So you can learn about racism, you can learn about bias, you can learn about sexism and sort of the inequities that occur. and then commit to being an ally, right? So you can learn how to be an upstander and not a bystander. And sometimes that's not easy, particularly in the beginning. But microaggressions, and that I think is a euphemism, right? So microaggressions are really racism and sexism and genderism. And so I think we all have to listen for them, and we have to hear them, and then we have to stand up and say it's not okay. And in doing so, that we are constantly educating people, and we are showing that we're committed to equality and to love and compassion and concern for people, and that we do not agree with the hate and the divisiveness that's being promulgated in our country right now. Those are not our values. That's not what we stand for. And be, sort of loud and constant and persistent in our commitment to bringing the country together and bringing people together, and promoting really values that are consistent with our beliefs of equity and compassion and equality for all.
And also I'd like to say there's going to be a lot of very hard conversations where people are not going to feel comfortable. I just had one 2 days ago with someone who was very close to me, who told me they did not think that there was any racism in the 21st century. And we completely disagreed. And but there's going to be more and more conversations about this. And people have to be willing to make mistakes, but be willing to make mistakes to be corrected on. And so people are not always going to feel good or comfortable in this space, but we all have to agree that we have to try to move forward in a forward trajectory. Otherwise, I don't know how much longer we can last going like we are now, but we have to make things inclusive and equitable in this country. And so I just want to say that it may be a little uncomfortable for a while, but we have to feel okay being uncomfortable.
And I would just echo Dr. England that it is going to be uncomfortable, but dialogue and conversation will be necessary, but not sufficient. And so the level of repair and disproportionate investment and kind of action, I think, is really the pressure is on to both talk but also act. And I think that then will really challenge us, because we are embedded in a set of systems that have been set up perfectly to get the outcomes that they currently get. And so how we work in those systems, whether it be with our elected officials, whether it be with our community partners or in our own institution, but the uncomfortable conversations and understanding there's a problem and then working together for real action, that's really going to be necessary.
Okay, thank you so much for your question, Annie. We really appreciate it. Are there any more questions in the audience? I'll give it a moment or two.
I think there was one from Mark Relly to how what's being done to make graduate programs more diverse, STEM programs specifically. And I think that one came through in the chat and not the Q&A.
Mm-hmm.
So
I think Dr. McKay actually touched on that a little bit, but if there's anything else that you guys would like to add, by all means, feel free to.
So in DBBS, which is the Division of Biology and Biomedical Sciences, which is the umbrella PhD program for biochemistry, molecular biology, immunology, they have a chief diversity officer. They have really looked at their application selection process to make it more holistic and to make sure that it's not structurally biased, and really mandated training, just like the vast majority of the medical school has mandated 4+ hours of unconscious bias training and anti-racism training. They and there have commitment for not only DBVS, but all of our training programs to be more diverse. So some programs that have been established at the medical school include diversity at the podium. So really in medicine, we have every division report on the proportion of women and people of color that are invited speakers, that are getting awards, that are giving conferences and set targets, so that they really have to be aware and have to do a better job getting at least 30% of the speakers to be women and at least 10% of the speakers to be people of color. And that's actually been incredibly successful, so that when we bring folks in from outside speakers as well, we can have them interact with more women trainees and more trainees of color, so that they get additional interaction and networking and mentoring from folks who look like them. And I think that makes a huge difference as well. DBBS has done a remarkable job and has increased the diversity of their trainees dramatically over the past few years. The medical school has also hired a chief diversity officer and associate vice chancellor for diversity inclusion, both on the medical school and on the Danforth campus. The senior leadership of the medical school, the deans and all the department chairs are having 2 days of training. The Crossroads training, which is an organization that's run out of Chicago, that's really based on the racial justice philosophy of helping people understand racism, the fundamental roots of racism, and how you can have people more effectively work together. So I think that's happening July 25th and 26th, which will be quite good as well.
Okay, thank you. I think I'm going to go ahead and wrap everything up, seeing that there are no more questions. I really just want to thank all of our panelists again for having this dialogue with everyone who attended. And if you attended either yesterday's panel or today's panel, I thank you as well. I hope you learned something new. And I kind of just want to take a moment to reflect the general feelings of our panelists, that, I really hope that, one, you did learn something new through these panels as I did, but also that you continue to educate yourselves, that you continue to have these dialogues and these conversations with people that may be uncomfortable. Continue to learn about these issues and learn about things like the spot, that you can support to take initiative against these issues. But most importantly, having these dialogues and having these conversations is not going to do anything without action. And one of the most important ways we can take action is exercising our right to vote, making sure that your feelings about the system and how it's flawed right now are represented in the ballots come election day. And that's really the most important thing that we all need to be doing. And I really hope that, the general, education kind of movement and general human rights movement is really going to be reflected in the ballots when elections come around. So again, thank you to everyone who came through. I'm going to follow up with everyone via email about future events and kind of wrapping up this whole discussion series that we had this weekend. But I had a great time planning it, moderating it, doing everything like that. And I hope we'll be able to do more events in the future. I will leave the contact information of our panelists in the follow-up email if that's okay. So, maybe they can answer more of your questions. And I look forward to seeing you guys next time. Thank you so much for a wonderful discussion.
Thanks,
Thank
Aiden.
you so much.
Yeah. Take care, everyone. Have a great rest of your weekend.
Bye.